All right, good afternoon, everyone. We will now begin our afternoon session with an important proclamation recognizing Older American Month. I will be joined by County Executive Mark Elrich, as well as Dr. Odile Bernetto, Dr. Patrice McGee, and Sean Brennan. Let's come before the dais. Well, hello, good people. So I have shared this story before, but I think it's appropriate to share it again. I was blessed to grow up in a multi-generational house in Bethesda. My grandparents sold their house in Silver Spring, and my parents sold their house in Gaithersburg, and we lived together from the time I was 11 all the way through college. And I was fortunate to be able to hear in the first person the stories of my grandparents and how they immigrated to the United States. But it was a profound experience because my mom was her sisters and brothers were in Chile, and so she was the primary caretaker for my grandmother and grandfather. And my grandmother developed Alzheimer's, and my grandfather developed Parkinson's. And I will never forget the love and the attention that my mom showed for my abuelito and abuelita, and the commitment that they had, that my mom had, to making sure that they were able to age gracefully and that they had the love and support that they needed. And I also realized very quickly that my mom couldn't do that on her own, that she needed help. And our aging community in Montgomery County contributes in every way imaginable. They contribute economically, they contribute culturally, they contribute academically. And I was taught from an early age that the mark of a strong community is how it treats its elders. And so it's appropriate that this month we recognize our aging population here in Montgomery County, all of their continued contributions every day on behalf of our community, and the foundation from which they have laid what we all benefit from right now. So I am thrilled to be joined by the county executive today, and I will ask him to say a few words now. County Executive Mark Elrich.
So thank you, and I'm very happy to be here today. I come from being over at the launch of, I guess, Cadence over in Albany, the senior center at 88 independent living units and 41 memory care units, and it's a really beautiful facility, and it's new, and they talked to me today about they're going to be opening a second one. They plan on breaking ground and bringing another one to the county. And these are critically important because many people who aren't able to age at home, they need alternative sites where they can age and age safely and have the camaraderie of people around them, and at the same time be safe in their environment. So that was kind of the start of my day, and I'm really happy to have done that today. We're proud to be an age-friendly community. We launched our age-friendly action plan in 2020, and we're designing the county to meet the changing needs of the people who live in the county. We have programs that help people live at home, that help them make repairs to their houses, help them maintain things so they don't have to lose their house because they can't do the maintenance themselves. And as hard as it may be to believe, there are people who couldn't get up on a stepladder now and change a light bulb and do that safely. And the ability to help provide supports for people to do those little things, which makes it possible for a person to stay in their home, is really, really critically important for people. This budget has $68 million in resources for seniors and senior services. We've increased staff in the HHS departments to investigate complaints of abuse and neglect among seniors. We know this is one of those crimes or a set of crimes that actually have ticked up. And so we're putting more resources into this to make sure that we can help seniors not be taken advantage of. We've got support staff at a new South County Regional Senior Center facility that's going to be opening. There are a lot of things that we're doing and will continue to do, and this has always been a joint effort of everybody on the council. This is one of those issues where everybody is on the same page. We all understand the critical importance of being able to do this. So I'm happy to be here today and be a part of this. And I'll close by saying, among our many volunteer programs, we have a group of seniors who help people prepare tax returns. And I had the privilege the other day to greet them and thank them for the work they were doing. And this group of individuals filed, $3 million worth of filed returns that generated $3 million in refunds for the senior residents of the county, and who they know would have had a very hard time navigating those forms and doing that work if it hadn't been for the support of this group of seniors who wants to give back to the community. It's just one of many examples of the work that seniors are doing in Montgomery County. So we want you to feel comfortable here. We want to make sure we make this the best place for a senior to live, whether you decide you're going to be in an apartment or stay in your single-family house, whatever you choose. We want to make sure you have an experience that makes you happy you're in Montgomery County. So thank you.
Thank you. Very well said. Next, we are going to hear from Dr. Odile Bernetto, the Chief of Aging and Disabilities with the Department of Health and Human Services. Dr. Bernetto.
Thank you so much, Council President. Good afternoon, everyone. It is clearly a pleasure to be here for this joyful occasion to celebrate with our colleagues across the nation for Older Americans Month in the United States. And so, as you heard from our county executive, we are so fortunate to have so many seniors, so many older adults who are contributing every day to improving the well-being of the life in our community for children, for grown-ups, for older adults, and also wanted to point out that the age-friendly initiative that we started in 2015 is going really strong. We got recertified by the World Health Organization and AARP in 2020, and we are now putting together our updated document to submit to them so that we can continue to be in good standing as an age-friendly community. And so also wanted to recall to help people remember that if you know a person who is an older adult who needs assistance and need help, please contact our office at 240-777-3000. We have a team of staff who are very knowledgeable. They have worked together in our locality for many years. They know the resources, so please do contact us. We can help them. We can help their family members and their caregivers. So thank you again for this joyful occasion. Back to you.
Thank you so much. So one of the most effective commissions in Montgomery County is the Commission on Aging. And I have had the pleasure and honor of working with them for 16 years now, 12 as the director of the rec department, and now 4 here on the council. And I have always been deeply impressed with the due diligence and the level of effort they put forward in making their recommendations to both the executive and the council every year. And carrying that tradition of strong leadership is Barbara, the current chair of the Commission on Aging, and I'd like to welcome her to say a few words now.
Thank you. Thank you so much, Council President Albernas. I am so lucky to live in Montgomery County with a county executive and county council that really cares about the older adult population in Montgomery County. They have worked diligently for many years to make Montgomery County an age-friendly community and a community for a lifetime. We are so fortunate this year to have from the county executive one of the best budgets for the aging population in many, many years. And we are so grateful to all of the support that we receive throughout the year from the County Council and the County Executive. Thanks so much.
Thank you very much, Barbara. I believe we're going to read the proclamation now. So, Mr. County Executive, you can come forward. So, proclamation of Montgomery County, Maryland. Whereas Montgomery County is dedicated to the diversity, equity, and inclusion of programs and services that aid older adults as they age in place. And
Whereas Montgomery County is steadfast in ensuring our diverse older adult population remains connected to the community, and
whereas Montgomery County's 60 years and older population currently makes up 21% of the county's total population, with a projected growth to 35% from 2020 to 2040, and
whereas Montgomery County acknowledges the unique and varying degrees of needs among older adults and is committed to supporting how older adults participate, explore, and make connections as they age in place, and
whereas Montgomery County is a better place when people of all ages, abilities, and backgrounds are considered, celebrated, comfortable, and connected to their community as they journey throughout their life cycle, and
whereas Montgomery County is an age-friendly community that promotes independence, ensures accessibility, and offers robust programs and services that afford older adults the ability to choose how they age in place, and
whereas Montgomery County is a culturally rich community committed to the safety, independence, and respect for all older adults as they age in place regardless of income, age, or abilities, meeting older adults where they are and ensuring community supports as they journey through life on their terms, and encouraging people of all ages to celebrate connections, diversity, and independence. Now, therefore, it be resolved that Mark Elrich as County Executive and myself as Council President hereby proclaim Older American Month in Montgomery County and ask residents to join us in recognizing older adults and the people who support them as essential contributors to the strength of our community. Signed on this 19th day of May in the year 2022 by myself and the County Executive. All right.
yeah.
Let's take a picture. All right, we're going to take a short recess until 1:30 when we will resume with our public hearing and actions. All right, we got a quorum. Let's go ahead and do the countdown.
We are live in 5, 4, 3, 2, 1.
Good afternoon, everyone. We will now resume our full council session, and we start with item number 16, which is a public hearing in action. This is a public hearing on a special appropriation to the county government's FY22 operating budget of the Department of Recreation, Youth Development, in the amount of $250,000 for after-school youth support engagement hubs, and an amendment to the FY22 operating budget resolution 19872, Section G, FY22 designation of entities for non-competitive contract award status, Montgomery County Collaboration Council for Children, Youth, and Families. I believe there is one speaker for this public hearing, and is that in person or virtual?
In person.
In person. Would the speaker please come forward?
Swinefeld? Yes. Have a seat, please.
Yeah, thank you. This is my, Yeah, thank you. This is my third time giving testimony. The first time I was very successful. I was the only county resident for the smoking regulations on property. I am Christine Feinfeld of Silver Spring, Maryland, a retired ride-on bus driver. You see my ride-on bag over there. And a volunteer for the Department of Recreation Therapeutic Swim Program. I come in every Saturday from 9:30 a.m. to 11:30 as a swim aide to help children, several on the autism spectrum, to enjoy the water and introduce them to swimming. The county charges for the class, but I get nary a thanks, not even a swim pass to get in free. The county might as well have told me virtue is its own reward. I'm also a retired county employee. Current county workers, as part of the health wellness program to keep health costs down, get a free swim pass and other discounts on recreation upon application. Most retired county employees count on the county subsidizing their health benefits in retirement. It would be a savings to the county to give the same swim pass to its retired employees. Recreational swimming promotes relaxation, aerobic exercise, and for those unfortunate enough with arthritis, movement, all promoting health and keeping the health costs down for both the county and the retirees. No extra costs are involved. The pools are there. The lifeguard is there. The water is there. I've written to the council, to every one of you, and the health benefits manager with nary a response from you.
You're over time, but you're the only speaker, so please, if you'd like to proceed, but if you could work towards a conclusion, we'd appreciate it.
So we're both as a volunteer. It's right that you give some benefit to these volunteers. Yes, we do have student getting their service credits, but what about the retirees? I'm in my 70s years. I spent most of my lifetime doing some kind of volunteering at the Smithsonian, Insect Zoo, for so many different organizations, and I've been volunteering for the swim program, the therapeutic swim program, on and off for several years. But what do I get? Nothing. Nothing.
Thank you so much. I understand the point. I really appreciate the testimony.
So you're spending $250,000. Put some of this towards the volunteers in the therapeutic swim, and retired county employees deserve better than they're getting now.
Thank you so much.
Thank you.
And with that, this public hearing is now closed. This is a public hearing in action. This is to appropriate $250,000 for after-school youth support and engagement hubs. Can I get a motion to accept this special appropriation? So moved by Councilmember Rice, seconded by Councilmember Friedson. All those in favor, please raise your hands. And that is unanimous among all those present and virtual. Thank you. That moves us on to item number 17, which is a public hearing in action. This is a public hearing on a special appropriation to the county government's FY22 operating budget for the Office of Community Use of Public Facilities and its Facility Fee Assistance Program in the amount of $125,000 for Youth Out of School Time Initiative. There are no speakers for this public hearing, and so this public hearing is now closed. Can I get a motion to accept this special appropriation? Moved by Councilmember Rice, seconded by Council Vice President Glass. All those in favor, please raise your hands. And that is unanimous among all those present and virtual. That takes us to item number 18, which is a special appropriation number 22-86 to the FY22 operating budget of the Montgomery County Government Department of Health and Human Services and Maryland Department of Housing and Community Development Emergency Rental Assistance Program in the amount of $8,800,000. Action is immediately scheduled following this hearing. There are no speakers for this public hearing, and so this public hearing is now closed. Can I get a motion to accept this special appropriation? Moved by Councilmember Katz, seconded by Councilmember Friedson. All those in favor, please raise your hands. And that is unanimous, again, among all those present and virtual. Next, this is a public hearing on special appropriation number 22-85 to the FY22 operating budget of Montgomery County Government, Department of Health and Human Services, and Maryland Department of Housing and Community Development Emergency Rental Assistance Program 2 in the amount of $6,488,000. Action is immediately scheduled following this hearing. There are no speakers for this public hearing, and so this public hearing is now closed. Can I get a motion to accept this special appropriation? Moved by Councilmember Friedson, seconded by Councilmember Navarro. All those in favor, please raise your hands. And that is unanimous, again, among all those present and virtual. And that takes us on to item number 20. This is a public hearing on special appropriation to the county government's FY22 operating budget of the WorkSource Montgomery non-departmental account in the amount of $3 million for COVID-19 workforce support programs and an amendment to the FY22 operating budget resolution 19872, Section G, FY22 designation of entities for non-competitive contract award status, sources WorkSource for WorkSource Montgomery. Action is scheduled immediately following this hearing. There are no speakers for this public hearing, and so this public hearing is now closed. Can I get a motion to accept this special appropriation? Moved by Councilmember Rice, seconded by Council Vice President Glass. All those in favor, please raise your hands. And that is once again unanimous among all those present and virtual. And then finally, this is a public hearing on a special appropriation to the county government's FY22 operating budget for the Office of the County Executive in the amount of $4,690,000 for its COVID-19 Business Rental Assistance and Hotel Relief Program, and an amendment to the FY22 Operating Budget Resolution 19872, Section G, FY22 Designation of Entities for Non-Competitive Contract Award Status, Latino Economic Development Corporation of Washington, D.C. Action is scheduled immediately following this hearing. There are no speakers for this public hearing, and so this public hearing is also now closed. Can I get a motion to accept this special appropriation? Moved by Councilmember Friedson, seconded by Council Vice President Glass. All those in favor, please raise your hands. And once again, unanimous by all those present and virtual. All right, that takes us on to item number 21.5, which is we will now sit as the Board of Health And we had requested this session in light of the growing numbers and news recently that the public health officer position was unfortunately once again turned down by a finalist for that position. I want to welcome Dr. Bridgers, Dr. Stoddard, and Sean from our public health team. I also welcome and thank Chief Administrative Officer Rich Madalino here. Why don't we start before we go through the presentation so Mr. Madalino can, I know has a lot on his plate these days, as is always. But Mr. Madalino, I know that Dr. Kroll could not be here today, and so thank you for representing the administration. My colleagues and I are all interested in hearing about the status of the hiring of the public health officer. We agree on the urgency. We know the executive branch does as well. We acknowledge how challenging it has been, especially in this environment, to hire public health officers across the country. And we also agree that Dr. Bridgers and the team have done an outstanding job leading in an interim capacity for the last months. But we also agree that this is a critical and important position that must be filled as soon as possible. And we all received a fair amount of correspondence and concerns from a number of different stakeholders out in the community over where the process is at this point. And of course, there's concern that with a change in governor looming in November, that could extend this even further. And we'd like to just hear directly from the administration with regards to the status and the plan moving forward. So with that, Mr. Madalino, I'll turn it over to you. Yes.
Oh, that one. It's all new. I'm sorry. Thank you, Mr. President. I appreciate the opportunity to be here. For the record, Rich Madalino, Chief Administrative Officer. And before I start, if I may, thank you all for your vote on the capital budget, the operating budget, all of your work, all of the staff work in getting us to this point. The county executive, the whole county government greatly appreciates it. And also a moment to thank Councilmember Navarro, Councilmember Rice, Councilmember Reamer for, I know how hard it was to hit that button the last time on a state budget, so I greatly appreciate all of your work. And it's been an honor to serve with you for, I think, 16 years, 14 years, 12 years in this community. So I greatly appreciate it. With that said, I do want to start by saying for you, for the council members, for our community, we have an outstanding public health team. Dr. Bridgers has been fantastic in an acting role. Of course, Sean O'Donnell has stepped up kind of in an informal acting deputy role to help explain what's happening with COVID to the community. And of course, we're always augmented by the presence of Dr. Stoddard. So it's a great team from top to bottom, not just the leadership, but throughout the public health service, HHS, and across county government. So it's always important to note we are in a very strong position. Very quietly, 3 senior administrators in public health, as you probably have noticed, have retired. And new people have come in and taken on those jobs in a full-time role. So we have been able to fill those positions. It's this interesting quandary that we have with our health officer position. I would note the 2 gentlemen to my right who have been fantastic leaders, Dr. Bridgers and Dr. Stoddard, would be eligible to be a health officer in 23 of the other 24 counties in Maryland. But we have a unique situation where we limit our health officer to be a licensed physician. And we have found it difficult to get someone over the final line on the selection process. We brought on a search firm right away. We had 150 candidates identified. They forwarded 15 names to HHS. 5 candidates were brought in late October. We had 3 candidates make it to the county executive. We found an amazing licensed physician who was bilingual, who I was incredibly excited about, who wound up with an opportunity in the private sector in a way that we simply could not compete with. We went through that again with two other candidates who also wound up in non-governmental positions as part of their search. So at this point, as you mentioned, Mr. President, the one thing we know for certain is we will have a new governor come January. This position reports to both the state secretary and to the county government. So as we've talked to candidates, as I've been part of the interviews, people have asked, what can I expect out of a transition? Because we have a local election and we don't know what the outcome of the local election is going to be. And so when you ask someone, disrupt your personal life by taking a new job and in several cases, relocate your family, and as much as I sit there and say, oh, trust me, a health officer is never going to be fired. Who would ever let go of a health officer? I can't absolutely guarantee that. You could have an outcome with a governor that says, I want to fire every health officer. And then you say, we're not going to fire our health officer. And what sort of pleasant working condition is that? So I fear we are in a situation where it would be the fall to best that we would be able to present a new candidate to you because of the uncertainty that is lingering about making a commitment, a large commitment to a change. With that being said, I think we need to have a conversation. Was the chair of the HHS committee with many of you who have worked around these issues for a very long time about how do we want to structure HHS in this position moving forward? In 23 other jurisdictions in the state of Maryland, the health officer is the director of the local health department. Our health officer is a division chief within Health and Human Services. So it is an interesting difference between our one jurisdiction and the 23 other jurisdictions. Dr. Bridgers and I were talking yesterday, 13 of the current health officers across the state are not licensed physicians. State law says you can be a licensed physician or have a master's in public health. We are the only jurisdiction that limits ourselves to this position to be a licensed physician. We could change that and change that easily in the position description and broaden the pool of people who could be the health officer. So, or just separate the health officer position, we've talked about this, the health officer position to be sort of an advisor either to the HHS director or to the whole government on healthcare issues, and then have a division chief for public health services who continues to run that whole operation, because we have, if not the largest public health department in the state, we have the second largest public health operation in the state. So there are some decision points that we face, and quite frankly, we now have an opportunity to use this moment of transition to think about what the future holds for this position and the future of public health within the county government.
Well, I appreciate the candor and obviously the acknowledgement that none of us would prefer to be where we are. And through our best laid plans, we just have not been successful to date. And we have had outstanding candidates who went through almost the entire process and then literally at the 11th hour determined that they did not want to proceed.
Right. And this is an exceedingly long process too, because not only do they have to go through our whole process, once they make it through our process, we have to send it to the state, and the state secretary, Dr. Chan wanted to interview the last candidate, and then the state secretary wanted to interview the last candidate, and that added 6 weeks. Right there.
Well, given where we are, and we're about to get a presentation that is dozens of slides that describe yet another wave, and the fact that we've all acknowledged that the COVID-19 is never going away, just the varying degrees of it and its impact on the community will change over time. And obviously the public health officer position is important, not just in their responsibility in terms of COVID response, but in the coordination of the public, private, nonprofit sectors which Dr. Bridgers has done an outstanding job of along with the entire team. But he's doing two jobs right now, his old job and his current job, and that is not fair. And so what I'd like to suggest, Mr. Madaleno, in light of where we are in this process, is that we set up an HHS committee session in the very near future to have an extended dialogue on this issue, and that I would request that the administration come back to us with some recommendations on, and the pros and cons on each one of those recommendations given the current circumstances we find ourselves in. Because I think waiting until the fall, in light of everything that has been happening, would obviously be something we would all like to avoid. And especially if it goes beyond that, then at that point, it becomes even more problematic for a lot of different reasons. So, but I very much appreciate you coming forward and sharing that information with us today. I thought it was important for us to hear directly from you, frankly, as the highest appointed official within the administration. And also just underscore, I know this has been a priority for the administration. And we have worked in that vein.
And I am so very frustrated because we found, each of the finalists that we wound up coming, I would have loved to have worked with. I think you would have very much appreciated their leadership in the community. So I think this would be an exciting time for anyone want to work in this space in the state of Maryland. Right. There are so many exciting things that are happening right now in our state, in the healthcare financing arrangement, our commitment to equity, working on the social determinants of health. There are so many exciting things that are happening in our community and in our state that I've been disappointed that people have pulled out, because I've just thought, wow, from where you might be coming from, this is an exciting place to be. Well, but the uncertainty of the situation has made them think of other opportunities.
Yeah, and for anybody out there who's considering this job, this has been an extraordinarily supportive Board of Health, an extraordinary supportive council, and overall, especially as compared to most other jurisdictions across the country, a very supportive community. And so although there have obviously been extraordinary challenges and a lot of pain and a lot of terrible rhetoric that has been shared, which none of it is acceptable, by and large, we have a community and an infrastructure of 6 hospitals, primary care clinics, a very well-respected Department of Health and Human Services across the entire country. I mean, you're not going to find a stronger foundation of public health infrastructure than here in Montgomery County. And having somebody working with HHS and the team who can help leverage those assets is what we're looking for. It's not a transformation by any stretch of the imagination. It's just taking, it's already in many ways great and making it even better, is the bottom line. I don't see any questions or comments from colleagues, so I think you did a great job encompassing the context here, and we will follow up, Mr. Madaleno, on the HHS committee session I described, and of course, as is always the case, any of my colleagues that would like to join us in that discussion, please feel free to do so. I'd like to do that sooner rather than later. Ms. McGuire, if we can look at the calendar, certainly before the August recess, but as close to now as we can get it, because of the timing of all of this, it would be very important.
We'll work on that right away.
Great.
If I may, Mr. President, I do think that conversation that you want to have should also focus on some of the emergency powers that are granted or not granted. We have some very different structures in Montgomery County compared to some of our neighboring jurisdictions. As you may know, the executive can only, in a state of emergency, suspend the sale of firearms and alcohol. And maybe, that was probably a result of civil unrest in the 1960s. Maybe with what we've learned during the pandemic, we should think about some different powers to more quickly respond to some of these situations. And that's a conversation I think we also have to have structurally.
Open to that, and I agree with you. Council Vice President Glass.
Thank you, Mr. President. Thank you.
I could have gotten out with it.
Yeah, you're stuck. Appreciate updating us on the situation and the candor in which you come to us. I just want to understand for not only our knowledge, but for the communities as well. Is the county executive advocating that the qualifications be changed?
He is very much open to that. We had a conversation yesterday with Dr. Kroll to talk about how we should move forward and changing that requirement so that you have a broader applicant pool. That doesn't mean, state law says a licensed physician or someone with a master's in public health. We say just a licensed physician. So it might be open, we might be wise to open it to, like all the other jurisdictions, both of those qualifications and see who we get. Now, state law also says that if the health officer is not a licensed physician, a deputy health officer has to be a licensed physician. Many of the other jurisdictions, who are much smaller than us, use a part-time community doctor who is the health officer and provides especially the responsibility for signing the orders. Because when we have a vaccine clinic, there's a doctor who has signed an order, and they use that sort of community physician to do that, as opposed to someone who is employed full-time by the Garrett County government or the Somerset County government.
Understood. And the language that we're referring to being a doctor and or having a master's degree, is that codified in law? Is it just in the job description? What actually needs to be changed from your vantage point?
The language about a licensed physician or a master's degree in public health is in state law. We have a position description that says that the minimum qualification is to be a licensed physician. We have to alter that, send it to you, and then have you, because it's an appointed position, then you have to approve that.
Okay, so again, just level setting, you are seeking our approval to change the job description for the position for which we ultimately would need to approve.
We started that conversation yesterday. If the executive wants to submit that to you, that's the process.
Understood. Clearly, I think we need to fill this position as quickly as possible with the best person possible, and do so in accordance with state law. Thank you.
Thank you. Councilman Navarro pointed out correctly, I'm sure that some of this discussion likely does, much of it crosses over into government operations. So we will work on a joint committee meeting as such, for sure. Did you want to speak, Councilman Navarro, or?
No, not really. I mean, I do thank you for explaining all of this. Obviously, we have all been so busy. We did not anticipate that perhaps we should have tried to have that flexibility earlier so that we could have a bit more of a runway. As you just described, we have extraordinary folks already doing this type of job. And I honestly had not realized that we were the only ones. I thought that this was codified in state law. That's how I had been approaching this. So yes, I think the sooner that we can have that conversation, it just gives us that flexibility, which is going to be really important given what we are now experiencing. It's not done. So yes, I think that having a joint, GOHHS and then examining all of these different caveats, including the issue about this state of emergency, will be important to update. As you described, it seems like there's just a lot that has been on the books that refers to circumstances that happened a long time ago, and we need to update those. So thank you for that.
Thank you. Councilmember Friedson, followed by Councilmember Reamer.
Thank you. I appreciate the update. This is obviously not a situation that any of us want to be in, and there are a lot of issues in our control and even more issues out of our control that relate to where we find ourselves today. I think we all need to acknowledge that and understand that it's not an easy time to be a public health officer, not just in Montgomery County, but anywhere in the country. And there are a lot of jobs right now where we're struggling to recruit, and it's partially based on the way that the public conversation is going related to these issues. And, we can lead by example and we can try the best that we can, but we can't change the environment that we find ourselves in. So we have to adapt to the environment that we find ourselves in. I'm just curious on this. Have you worked at all or been in contact with the association with MACHO, the Maryland Association of County Health Officers, to discuss this issue and get any recommendations from them?
So I personally have not. I know Dr. Bridgers participates with MACHO all the time.
Yeah, I meant you collectively. This wasn't directed at you the chief administrative officer, but the executive branch of government broadly that's responsible for finding the position. I'm just curious as to, if they've provided any feedback or any, suggestions based on this and whether that's
For candidates or for structure?
Well, both, since I think
Okay.
they're both related to the same issue. So you've had those conversations. I we don't need to go too far into it, but I was just wondering if that conversation had taken place.
So good afternoon, Councilmember Friesen. Yes, we've had those conversations, but not to the level of detail that maybe the council sitting as the Board of Health or the county executive. I provide Major with an update monthly during our meeting, and we caucus about those other the clinical aspects of being a health officer and what the demands are regarding that. The health officers have also made recommendations based on other clinicians and medical providers within their jurisdictions and provided those names or had them follow up with the county's recruiter. So we've gone that path, but any additional detail regarding specificity or information, we haven't gotten into those details, but just where we are and what the needs are of the county.
Yeah, I think it'd be helpful. I mean, they're tasked with advocating on behalf of health officers to change state laws to address state issues. This is related to that, so I would recommend that conversation take place. The last,
And I'm also keenly aware that with elections happening in all 24 jurisdictions this year, there may be other people who are interested in new opportunities in other jurisdictions across the state.
Sure. We still have the deputy challenge because the state law, what you're saying is our public health officer has to be a licensed physician. State law requires either the public health officer or the deputy. One of the two must be a licensed physician. If the county executive proposes formally what you have suggested informally here, based on the conversations that have only just begun, it seems, how do we address the state law requirement? Wouldn't we still need to
We would then
hire a deputy?
We would need to find a deputy who would be the licensed physician.
Yeah. So, I mean, more conversation to go more in depth at this proposed joint committee, which I look forward to. But it seems to me that the job description is not going to solve the problem in and of itself, because we still have a challenge of finding a licensed physician who's willing to take one of these two jobs and what these jobs are, whether it's running a department in the public health department and being the advisory role of the public health officer, the secretary and executive officer of the Board of Health under state law, or separating out those functions. I think we talked about it as if it's the physician requirement that's unique to this program description for this particular job, but it's a broader issue than that, because we would then have to, if we change the primary role, we'd have to then change and find someone to fill in the deputy role that meets the requirement that we're unable to fill in a higher paid, greater responsibility job. So, we're going to trade one problem for another unless we deal with the root issue here.
But a majority of the other counties function that way, and they've been able to find a licensed physician who can serve in a deputy role for as the health officer. So it is certainly the more common model across the state than having the health officer be a licensed physician. During much of the pandemic, the state health officer was a registered nurse, Deputy Secretary Phelps. So it's just it is interesting that other jurisdictions have managed to find this a way to attract a licensed physician in the deputy role.
The way this is often done in other jurisdictions is to have them. They might be designated as the deputy secretary, but they're in charge of the TB clinic, for example, and so they're not necessarily a full-time dedicated to public health position. They may be another role within Health and Human Services that requires a physician, but they're given a sort of an additional. They're also the deputy health secretaries for the purposes of being that physician guidance that is required by law, and so they wouldn't necessarily have to do the full functions of what Dr. Bridgers was doing for Dr. Gales when he was here. They would be designated within the department. They'd have to clearly be an employee of the department and of the county to serve that function, but that would not necessarily require that they have all of the other responsibilities of a health officer or a deputy health officer.
Right. Okay. Thanks. Yield back.
Thank you. Councilmember Reamer, followed by Councilmember Hucker.
Thank you. So why don't we do that? Change the requirement for the chief medical officer position to allow a wider range of people to apply. I mean, Dr. Bridgers is a deputy, but we aren't limited in having just one deputy, right? We can have a second deputy who is providing the licensed medical role for signing those prescriptions. I recall very much when Dr. Gale said that he was signing the directive for testing. I think it was the initial. That was like when the first thing I realized this is why we have a doctor in this role, because you have to be a doctor to do that. And we are in a public health emergency. It seems like the public health field is broad, and there are people who have public health degrees who may not be licensed medical doctors. And for the foreseeable future, probably as long as, a next person would serve anyway. We're dealing with COVID, right?
So, right, and you have one doctor who is a PhD in public health.
Right.
With Dr. Bridgers.
And Dr. Bridgers would apply for the job, right?
You have one doctor, Dr. Stoddard, who has a master's in public health and a doctorate in Greek literature. Because I don't know, it's so many different terms.
Okay. So, like
Dr. Bridgers was wearing a mask, and you could still see that he didn't jump up at the chance.
Well, if Dr. Bridgers turned us down, then we really know something's wrong. In any event, I didn't realize that we had I always thought this was a state requirement, so I didn't know that we had the flexibility within our own county to adjust that, and it seems like we ought to do that quickly and be able to bring more hands on deck.
And we were remarkably well served by two incredibly long-serving health officers with Dr. Carol Garvey and Dr. Elder Tillman. So that was a very long time. I mean, the two of them probably served almost 3 decades.
Were they not medical doctors?
They were both. Yeah. They were both medical. They were both medical doctors,
licensed medical doctors.
But I think Dr. Garvey played a very different role. I think Dr. Garvey was more of that. I know she had a practice in the community. I think she was was more the medical advisor, and then someone ran the day-to-day operations of the public health service in an era when there wasn't even the joint HHS. I mean, her service started before HHS was combined under Mr. Short and County Executive Duncan.
Okay, well, I think we could have done this some time ago. Let's do it. I mean, we need to move quickly here and be nimble. So, okay.
Thank you. Councilmember Hucker, followed by Councilmember Katz.
Just quickly, I wanted to follow up on Councilmember Glassman's question. So if you've presented this, I mean, the county executive is obviously aware of this problem over and over. Is there any concern? Why not just recommend to us that we change the job description? That would give you the flexibility you're looking for. You're not going to hire anybody you don't want to hire.
So
what's the downside?
To be fair to the county executive, we had this conversation yesterday. We met
for the first time, though?
No. But we met with the county attorney's office last night about how to proceed with, do we just do this ourselves, or do we have to, is this something that has to come back to you? So I just don't want to tell you that the county executive is 100% on board with this, because I haven't got his final sign off on it, because I have to present back the idea of, you ready to submit something to the county council?
Now that you know what the process is.
Yeah.
But didn't you have this conversation with him last time? The previous applicant turned us down? This isn't a new issue. That's what my surprise is.
Interestingly,
or maybe you see concern.
We actually talked to some of the applicants afterwards and said that, hey, would this have been more attractive this way? And the answer was no. So, but maybe it's time to align ourselves with the other jurisdictions.
Was there any downside that you saw, or that you sensed the county executive saw? Wondering why you haven't made the recommendation, except for just timing. Okay, I'm done. Thank you.
Thank you.
Thank you, Councilmember Katz.
Thank you, and I will be brief. Do you know why the original job description would have been written the way that it was written?
So it was written in 1987. So, which is the year I graduated college. So I don't know.
So you didn't write it,
So
is
I
what you're
did
telling
not.
me.
I did not write it.
Okay,
and
so you're.
I don't know who was in the room. We have a lot of long-serving people, but maybe you.
Yeah, I did not
Councilmember
write it.
Katz, So,
I was.
but the
I had
date on
graduated
it.
college
The date
by
on
then.
it is 1987.
So, and then the only other question is, and we keep bringing up, that why this wasn't brought up before. Before we found people who were extremely qualified, who did this job for many years, and in fact, because of a tragedy, someone, passed away, and et cetera. And then we were very fortunate to have Dr. Gales and others step up. So even if we were aware of the problem, it didn't seem like it was a problem. Now we're aware of the problem, and it is a problem. So I think that if, as quickly as possible, if you could send over the suggestion for what you would like to have, and that we could change to be like the rest, then I think we would be much better served. Thank you, Mr. President.
I think just about in every community in this country, the health officer has gone from someone who probably no one could name or recognize to, depending upon your perspective, a hero or villain who almost everyone knows. So it's a very different type of position now to recruit for.
Thank you. Just summarizing a couple points here. I think it's been about 8 months since Dr. Gales stepped down. Typically, a position like this takes around 6 months to fill. So we're not that far out of the ballpark, but I guess acknowledging where we are right now, and we did have finalists who met the criteria, but in the 11th hour pulled out. And that gets us to the point where we're at now. So I understand the administration in real time is processing this, but as you heard from my colleagues, we're very open to, as sitting as the Board of Health, a discussion with recommendations from the executive branch with pros and cons, taking into account every aspect of this that we have already talked about. So we will schedule this joint committee session in short order and look forward to seeing that memo with the recommendations from the county executive on now, given the information we find ourselves in, how do we proceed?
Mm-hmm.
All right, thank you all. Thank you, Mr. Madaleno. We're going to go now to the actual COVID update. We have a series of slides that Dr. Bridgers and Mr. O'Donnell are going to share with us regarding this most recent wave of COVID-19.
Council President, I just want to apologize in advance. I do have to leave
No
in a
problem.
few minutes, so I just wanted to thank you.
Thank you. Dr. Stoddard, was there anything you wanted to mention before you have to leave?
Just a couple quick points. And so we have gotten some requests from different partners for rapid tests with this escalation in cases. We've got a request from the child care providers that we are likely to provide them additional rapid test kit distribution. We've also got requests from some of our municipalities. We're going to do another distribution with the municipalities that have requested. Maggie Nightingale Library in Poolesville opens on Saturday. It will also have rapid test kits, which will expand access in the up county as well. So I want to make all three of those points that of a lot of rapid test kits interest right now, and we're trying to meet that demand. So thank you.
Great, thank you. Dr. Bridgers and Mr. O'Donnell.
Good afternoon, Council President Albornoz, Council Vice President Glass, and the entire council sitting as a Board of Health this afternoon. Here we are with another update. We thought that we had a wavelet on the heels of Omicron, and then we're seeing a more significant surge in cases with multiple Omicron subvariants in the international and national community. But we are vigilant. We are resilient, and we continue to move forward with those four primary areas of focus that our team continues to aptly respond to: masking in congregate settings, masking and support for those individuals who are immunocompromised, and then looking at making recommendations when there's a need to have masking in indoor spaces with limited social distancing, vaccines, equitable and accessible vaccines across the lifespan. We continue to work with our partners to have ensure that they have initial series, first booster, second boosters, and then we hope this afternoon CDC's Advisory Committee on Immunization Practices approves the 5 to 11-year-old boosters so that we can get our school-age students boosted. Then treatment, test to treat, access to antivirals in the community. We've also canvassed our safety net providers and our other community providers to have greater access. They are proven antivirals, and we want to get them in the community and have access for all. And then lastly, as Dr. Stoddard indicated, testing. We've had multiple conversations with our independent and our public school partners and our early child care providers. We understand the importance of parents being able to work and have their children in a safe environment, and students be able to go to school and learn. We know the risk associated with loss of learning, and so we continue to work with our partners. And then lastly, before Mr. O'Donnell goes into 40 slides, yes, comprehensively 40 slides, we wanted to take you where we are now, look at where we're going, so when you come back from break, you can rest assured that we are safeguarding our community. And then to Council Vice President Glass, we talked about the next normal and shots. Mr. O'Donnell's going to walk you through shots very extensively, comprehensively. And to Council Member Hucker and Reamer, we talked about wastewater surveillance. Well, I'm glad to say within the next month, we may have that capability in the county. We've worked very diligently to bring that early surveillance tool. Now, I must admit that it's an emergent resource, but we will have that emergent resource, and we look to stay ahead of the game. So I'll stop there. I'll let Mr. O'Donnell run the show and provide you with all of the things that we continue to do and we anticipate on doing, either at a low community level, a medium community level, or a high community level. And keep in mind that all of the things that we do are additive based on where we are with our case numbers, our community level transmission and spread, and more importantly, the burden on our healthcare hospital industry. So I'll stop there.
Thank you very much. I know we've already given you an idea of the amount of information we have. We've included a number of slides covering our new normal plan for how we plan to operate with COVID appearing to be here for the extended period of time. Happy to move through that as quickly or answer additional questions if you have. But I want to make sure that we have time to answer the questions that you all have about what we're doing. There we go. So to begin with, I just wanted to give you a brief update on where we are with our transmissions and our community levels and our hospitalizations. This data is moving quickly. As of recently, we were at a point, you can see even from the graph here on the left, where it was a more gradual set of increases, and we had models that predicted that this would turn around by this point. You see that right when we got to around 200 cases per 100,000, it takes a steeper slope. We'll share with you some data from some other jurisdictions, some other states that are seeing the same thing. This very well may be a second variant that's come into play and has disrupted what our initial projections were and is now leading to ongoing increased transmission. So we're currently at 381 PCR positive cases identified per 100,000 over the last 7 days. Our new hospital admissions are 6.3 per 100,000 over 7 days, and our staffed inpatient beds are 6.1%. Again, the number, we're using CDC metrics here, and that number of hospitalizations, notably the CDC is using a combination of more than just Montgomery County. It includes some of Prince George's County and some other areas. We've been tracking along where how these latest cases are affecting our populations, both age-wise and distribution by race and ethnicity. Back in the December and January BA1, very, very large Omicron spike, we did note that there was disparities in who was becoming cases. We saw higher case rates with our Hispanic populations and our non-Hispanic Black populations at that time. We are not seeing those disparities at this time so far, but we are tracking those. So what we're sharing here is data in purple is from the last 4 weeks, data in pink is from the previous 4 weeks. Now these are both, at this point, these are both during the current wave, but we haven't seen a notable change amongst these. In some cases, what we do know is in the previous Omicron spike and the current one, a lot more infections are occurring at younger ages. These are folks who are in congregate settings, whether it's work, school, childcare. And we know that our population base is different down racial and ethnic breakdowns when you look at different age ranges. So these are, by and large, reflecting where we are in the county. So we're not seeing as much disproportionate impacts to the case rates. Looking at our test positivity, we're currently at 5.82% test positivity. That is the lowest or one of the lowest in the state. We have a lot of testing that is likely occurring through employers and through other asymptomatic individuals. That's helping them catch cases, but is also keeping our test positivity a bit lower. The test positivity at the county-run sites is significantly higher, around 17%. So we are likely seeing a lot more of the symptomatic individuals coming out, or people who've done a rapid test and want a confirmation. So to share with you some of the primary guidance that the CDC recommends and that we are, again, promulgating out to the community. When you're in that medium level, which we are firmly in now, obviously to stay up to date with your COVID-19 vaccines. One piece of data, and this is from the entire nation, not just Montgomery County, but since January, individuals who are 50 and older who are vaccinated but not boosted had a 2 to 3 times greater likelihood of hospitalization than those who were up to date on their vaccinations. This is why we keep telling people it's not enough. If you're in a high-risk group, it's not enough just to have those first 2. You should be boosted. And so much of our county, especially the older populations, if they got only their first 2, it's been over a year. So strongly recommending that. Wear a well-fitting mask around others. This has not changed. If you have symptoms, if you have a positive test or an exposure to someone with COVID-19, you need to wear that well-fitting mask for at least 10 days, or if in the case of symptoms, until you get tested and determine whether that's COVID or not and your symptoms have passed. The CDC recommends you wear a mask on public transportations. We understand that the mandate for that has undergone legal challenges, but it still makes sense to wear a mask when you're around other people, especially when you're in this higher level of transmission as we are. And then as an additional precaution, the recommendations that Dr. Bridgers has made out to the council a number of weeks ago, which is to protect others as well as yourself, to wear a mask when you're in congregate indoor spaces where there's limited social distancing and limited ventilation. The other strong recommendations: get tested if you have symptoms or you're exposed. Rapid testing, PCR testing, very available, even with the increases in case numbers now, even with the increases in testing we're seeing. We do not have lines at our county testing sites. We're happy to see people. We have take-home PCR tests that you can drop off, and we have lots of rapid tests available through the libraries, through other distributions we do with community partners. Again, one thing we'll get into is that the CDC no longer recommends universal contact tracing. The state and the locals who have always done contact tracing as a partnership, again, we're no longer doing every single person getting a call from a contact tracer. The focus is on the higher risk individuals. So that puts the responsibility on an individual who finds out that they're positive to let their close contacts know. Especially, obviously, if they're not reporting a rapid test, that's still your responsibility. And if you are at risk for severe illness from COVID-19, strongly recommended to wear a mask indoors in public settings while we go through this higher transmission level. And those individuals should talk to their healthcare provider about additional precautions before they have COVID, so they know what to do. In many cases, there's a limited window to begin treatments. So it's a good chance to talk with them, find out what would be a good course of action for those individuals. Speaking of those therapeutics and treatments, we spoke with our state partners a few days ago, and they assured us the supply of Paxlovid, which is the #1 recommended therapy for high-risk individuals who have COVID, The supply is plentiful of Paxlovid. This is the primary treatment that NIH recommends. As far as the eligibility, not everyone would be eligible for this. You need to be 12 and older, weigh at least 40 kilograms. You need to have tested positive for COVID and have symptoms, and it needs to be within 5 days of those symptoms. And finally, you need to be at risk for progression to severe COVID-19. In other words, you're at higher risk for COVID-19. And your healthcare provider can help you determine if you're in those categories. The very encouraging thing is that the data has shown that Paxlovid can, when taken in these situations, can help with an 88% reduction in hospitalization and death, which is, in addition to the benefits of all the vaccinations, is something that we really want to encourage people to consider. There are other therapies here, the monoclonal antibodies that can be prescribed. These are all prescriptions, though, as well as Evusheld, which is a monoclonal antibody that you receive once and provides those who are moderate or severely immunocompromised some protection before they're exposed to COVID. So we do recommend, if you're in that category of moderately to severely immunocompromised, talk to your healthcare provider and find out if Evusheld might be something they recommend, because we know the vaccines are not as effective for the people with those conditions. So in an effort to increase awareness of these therapies and access to these therapies, HHS has updated its website yesterday. We now have a treatment page. We'll continue to build this out with additional information about the specific therapies and how to access them. Currently, we have links to how to find test-to-treat sites, which includes how to find pharmacies who have these therapies if your healthcare provider has prescribed it for you. The test-to-treat, of course, it's a one-stop. You can be screened, get that prescription, and get that medication filled. There's also, we researched, there's also an option for individuals who don't have a healthcare provider, may not be able to afford out-of-pocket expenses of seeing a healthcare provider or getting that prescription. And there's a link here through the Baltimore Convention Center Field Hospital. They take both phone calls during business hours as well as have an online screening form you can fill out, and they call you back. And those are all offered free of charge. They'll ask for your insurance, but if you don't have it, they won't charge you any out of pocket. So we're continuing to explore other ways to ensure there's no barriers to getting these treatments. But one of the biggest things we need to do is promote that there are now therapies and people should access it. The state has pointed out with Evusheld that they have thousands of courses of this, and we know there's tens of thousands of immunocompromised individuals, and they're not accessing it. And so we want to promote this. One thing we wanted to share, I know this has come up in many discussions online and through communications. On March 2nd, the Maryland State Department of Education and the Maryland Department of Health issued an updated guidance for K-12 schools and childcare. And so we wanted to, again, just make sure folks understood where this guidance was. The key points, I know there's a lot on the slide, but the key points are that isolation and quarantine have not changed from the CDC's guidance on what those are and what the parameters are. But they did issue this guidance to help those facilities understand that as public health moves away from universal contact tracing, who is filling which roles as far as identifying symptomatic individuals and sharing notifications with families about whether there was exposure or not. And one of the key points in this is that MSDE emphasized that local school systems, the non-public schools and the child care, can choose to align their prevention with these guidances, can use an earlier set of guidance, or can, as private businesses, as long as they're not violating COMAR, they can set up their own criteria. But they share this out, and some of the key points are these programs, the guidance is that they continue to be responsible for identifying symptomatic individuals in their settings and excluding them from those settings so that they don't spread disease. In some cases, connecting them to testing to determine if that symptomatic person has COVID or something else. There's also, we've moved away from, in school settings, those individuals contacting, doing, again, the universal contact tracing, identifying all those contacts. They now do this at the cohort level. The either faculty member or the parents of the student who's positive, they're responsible for letting their close contacts know, as we said, everybody else is. And then the school or the childcare setting is responsible for letting the wider cohort, the classroom or the childcare setting, letting those parents know that there was an exposure, and then asking them to implement the CDC guidelines for quarantine or isolation. In this case, it would be quarantine. So again, that continues to be what it is. Obviously, it plays out a little bit differently in larger settings like schools and those classrooms versus some of the smaller childcare, as to the degree of the providers and their ability to share that information with all of the individuals or give them more specific information. But again, these are the guidance we provide to them. It is up to those providers to implement this. And if they have additional resources and want to implement more, they are able to do that as the MSD guidance has outlined. Finally, they are required to report to public health when they have these positive cases, and we use that to track in the outbreak investigations and to determine if an outbreak has occurred. Once an outbreak has occurred, then public health does work closely with them to provide additional guidance and direction.
Mr. O'Donnell, just really quick, I'd like to suggest, so I know there are 40 slides, but and this is incredibly comprehensive. I've got a couple of colleagues that have questions. If we could, as you have been, hit the high notes, and then sort of summarize those key areas that you would like the public to be aware of, and then we'll give colleagues an opportunity to ask questions. We still have one more vote that we have to take after this public health briefing, and we of course will be hopefully not having to have future briefings, but we thought it was important to get a moment in time check-in. But if you can just bear that in mind as you go through.
Happy to. Again, as we cover the very high transmission rates, one thing we want to share is we have had more modest hospitalization rates. We currently, as of the census today, have 80 patients across our hospitals and our alternate care site who are hospitalized with a COVID diagnosis. This has been increasing modestly, and again has put us around the 5% rate in the county, 6% rate across the CDC area. I will skim over the death rates. Again, just share, we find it very important to share with the public how protective being boosted is. This graph on the right shows that the death rate for those who are boosted is incredibly low compared to those with just 2 vaccinations or those who are unvaccinated. So sharing the latest CDC data on our regions, breakdown of the variants, you can see here that where we were predominantly BA2 for a number of weeks, we have now moved to a larger number of BA 2.12. That this very much corresponds to that sharper increase of transmissions, and that may be why we're seeing our rates continue to go up. We're hoping we can move through this again quickly with as few severe illnesses and deaths as possible. Just as I mentioned earlier, just sharing some of the data from other states, and you can see in comparison how they've gone up modestly, and many of these are the New England states, have gone up more precipitously over the last few weeks, likely in a similar rationale. This also gives you context for these are comparisons to their rate of cases, hospitalizations, and death compared to the largest peak prior to Omicron, and you can see that while the cases are approaching a similar rate, the hospitalizations and the deaths are much, much lower than previous peaks. Worldwide, the COVID cases are decreasing. In most countries in the U.S., it is up 31% over the previous 7 days. And this is a new chart just showing how those correspondences are specific to Montgomery County. The gray are the new cases happening per week, and the orange shows the relative hospital census of COVID patients. And you can see over the last two peaks, that ratio is much lower for hospitalizations to cases. Our vaccination totals have not changed notably. Of note, our 5 to 11-year-olds are approximately 63% of them are fully vaccinated. Those who were vaccinated more than 5 months ago will become eligible for boosters when the CDC and Maryland Department of Health gives us that authorization, and we're happy to provide those boosters to them. And again, we are tracking where those booster shots are going by age and by ethnicity. We are still seeing a disparity in our racial breakdown of who's accessing boosters. Our older populations are closer in that, but once we get to the younger populations, we see a very large disparity with our Hispanic and our non-Hispanic Black populations coming out for boosters at a lower rate. Most concerned about the older populations, but again, we're strongly recommending everybody get those boosters so that when or if they get COVID, it's a shorter illness, it's a less severe illness. I won't focus much time on this. We've already mentioned that the FDA has approved it. We're now waiting for the other two groups to approve it. And one note that the FDA had was all age groups they're seeing the waning of immunity in all age groups after the first two doses. To share with you, I mentioned that our testing has increased at our county sites. It went up about 19% last week. This week it went up another 20%. But again, we still have ample capacity to test individuals. We're just seeing more people come out, obviously, because of increased transmission. Again, just reminding folks that they can report their at-home test results to the state. Any rapid test results are not being included in the numbers that the state and the CDC report on cases. However, they can be used they are used for determining contact tracing for high-risk individuals, and we do use them again for other evaluations of where disease is and who it's impacting. So we do recommend people do this. It's not happening in appreciable numbers in any place. We realize a lot of people get their result and they want to go about their day. But if you have a positive result, we are asking you to record that. And then there's a questionnaire to determine if you are high risk or the people around you are high risk. We continue to distribute around 19,000 to 20,000 rapid tests each week at the libraries. We're now doing rapid tests and pick up PCR tests at 5 of our rec centers and at Dennis Avenue. And we have information there about which test people may benefit people more. Now, finally, I'm happy to go through this. I know that there's about another 12 slides that deal with our new normal response framework. I'm happy to go through very quickly. You all have that information about it, and then defer the rest of the time to questions. So the key areas that we continue to focus on, and by we, it's not just HHS or public health, it's the partnerships we have with everyone. And those three areas that we continue to work on is to maintain current threat awareness through surveillance, to communicate the risks to inform personal and community protective actions, to take those protective actions which reduce the quantity of transmissions and the severity of disease, and to continue the partnerships that have made this successful, and in some cases expand those partnerships. So again, I won't go through all of the specific points of why we're doing the surveillance or what we're trying to accomplish. I think you're all fairly familiar with that. But we are doing them to determine disease transmission, disease severity. We're doing syndromic and environmental surveillance, as Dr. Bridgers mentioned, with wastewater testing. We've long been doing syndromic surveillance. We work with our fire rescue service partners to look at the transports they do. We track when they're transporting more significant acuity patients and the volume. We also want to understand future threats. Much of the information I just shared with you is looking at data at the international or national level, and we do case modeling. The thing I want to focus on is where there's some key updates, what has changed in 2022 versus the previous years. There's an increased focus on a range of surveillance data. So we know that there's decreased community reporting of self-tests, but we have a lot of different data that help us understand the quantity and the severity of illness going on. And to understand how each new variant is affecting us, because they have different impacts to us. It's the introduction of the wastewater surveillance across the county to help us with early identification of increases in transmission and to complement the other surveillance data we have to better understand where COVID is occurring. And it's also to understand the longer-term COVID impacts and risks that we'll need some time from the onset of this to fully understand. 3 years in, we'll start to have better understanding of what long COVID is and how COVID affects different age groups. What do we do with all this data? We inform our decision makers and we inform the public so they can make the appropriate decisions. We do that through a series of dashboards that are, many of which are automatically updated. We do that through briefings like we're doing today. We are doing that through public information campaigns. We have one that is hopefully soon to go out that our PIOs are working on, and we do it through our neighborhood partnerships and outreach, as well as the public health reports we share with all of you and other stakeholders. The change here is the emphasis on the changing risks to individuals. Each of these variants has potentially changed the risk. Transmission is now happening amongst people who are vaccinated, but serious illness has changed. And we want to communicate that out to people. If there's an increased risk to different groups that has changed over time, we want to share that. We know that the risk for hospitalizations of younger people, while still low, has increased during the last few waves. So these are the sorts of things we want to communicate. There does need to be a broader community campaign for risk and resource awareness as people turn their attention away from COVID and towards other things. We still need to be able to let people know when those risks change and where to go to get resources as they stop going to our website every day. And we want to increase the use of dashboards so that information is autonomously available to individuals. And we're we're increasing our emphasis on community events where we can bring our resources to bear and meet people where they're gathering. Going into the protective actions, this is the whole range of what we're looking at, from public health disease control, including contact tracing, outbreak investigations, the guidance and directives that come from our health officer and come from the state and the federal partners. The personal protective actions, which we rely on individuals to do, staying up to date on vaccination, masking, social distancing and quarantine, and then access to health care. When all of those don't work and you need health care, it's the testing and outpatient care, the therapeutics, and the acute care, making sure that all of those are accessible and don't get compromised. We mentioned already the change in universal contact tracing. There's increased access now, as you know, to self-administered tests to ensure flexible and capacity. Even when things go up, transmission is very high now, but we're not seeing our testing overwhelmed the way we did before we had rapid tests. It's a layered approach to the interventions and the guidance, as you've heard from Dr. Bridgers over the last few months, and focusing on high-risk settings to try to control those and reduce serious illness in those settings, as opposed to needing to do community-wide interventions, as long as, again, our resources are not being taxed at the healthcare level. And then, again, with testing, vaccinations, therapies, and healthcare resources all available now, it's ensuring that these are equitably available to all of our populations. And the final piece of this, that where our focus continues, where a lot of our efforts continue, is all of these partnerships at the government, community, healthcare level, with all of our congregate setting partners and our essential community services and our volunteers, we're not going to be successful in COVID without all of these continuing. This has never been just a public health response. It is something that everyone has come together on. And so, again, the key changes over this past year is the emphasis is on the public's responsibility now to test, to isolate, and stay up to date on vaccinations. We're focusing our prevention and intervention actions with those congregate settings, and we're coordinating our public and private healthcare resources to ensure there's access. As those federal resources that have been supporting us change, we need to make sure that our partnerships continue to provide those to everyone in the county.
Thank you so much, Mr. O'Donnell. I appreciate it. I've got Councilmember Rice.
Thank you very much. So I want to go back to your report about the actual reporting of the tests, because I think that when we're looking at whether it's an antigen or a PCR test, it's important to understand what the positive result and where it came from, understanding that there may be human error associated with the antigen test more than PCR. If we've looked at separating that data to understand a little bit more about what truly is, but then also, I'm just curious, for me, from a sort of statistical perspective, I would also think that the number of negative tests that we get is something that also is important to know. All of us take them as we get exposed to different kinds of things, and it's important for us to know that folks are also testing negative. Has there been any guidance from CDC when it comes to either of those two things as a direction when we're trying to hone in a little bit more on being more strategic about our testing?
Well, that's a good question. We know that we originally set up a rapid antigen testing reporting site in the county, and it became apparent that it was going to cause issues with getting data to the state. And the state had set one up also, and again, for better movement of data and less duplication, we deferred to the state reporting site. The state site only will allow you to report positive results. From the perspective they've shared, the primary reason for those is following up with contact tracing. So they're less interested in the test positivity. We have looked at data in the recent weeks about testing volumes per capita in Montgomery County and our neighboring counties in Maryland. And next to DC, we have the highest per capita testing. We're also finding more cases because of that. But there is some sort of bell curve where you do more testing and then you reduce your test positivity by doing more testing. And it's okay. We do 100% testing in a number of scenarios in congregate settings such as correctional facilities or shelters. We want to catch every case there. We know when we're doing in the community, we're not catching every case. And when they're doing rapid testing, what's more important with the rapid testing is individuals know quickly if they have COVID, and then they take actions. And we think most people are being responsible when they find out that, yes, that cough is not allergies, that's COVID. They are then letting people know who they were with, you should go get tested, and so on. So we think that is helping. We know we're not capturing all of the data. We know that the state and the CDC are not including those rapid tests, reported clinical or otherwise, into those case counts. So we take that into consideration when we're looking at it. We know we say we're in high transmission. We are. We're in medium community level, but we are having high transmissions here.
And then my last question is around long COVID. There's been lots of now more recent conversations around that. I think that it certainly is something that, especially in our communities of color and socioeconomically impacted, to where we know that the cases were higher than pre-vaccinations, so those cases were more severe. There needs to be sort of an outreach to those individuals to be able to say, what are some of the continued symptoms you have, those kinds of things. What's been the conversation working with Por Nuestra Salud y Bienestar, African American Health Program, AHI, and others in the community to just try and flush out some of that and reestablish contact with some of those that we know were positive and just identify if they have the sort of symptoms of long COVID and then giving them the appropriate support.
So, Councilmember Rice, thank you for those series of questions. So we need to have more conversations, quite frankly. We've done some preliminary research and studies with our uniformed services, public health doctors who are residents under public health, and they've done a lot of research, not only with long COVID, but pediatric COVID responses as well. We didn't see the number of pediatric cases in the county, but we are studying them and the effects, because again, across the lifespan, it may not impact our pediatric population, but later on in life, it could have some additional challenges regarding inflammation, memory, and all those things associated with risk of contracting the virus. So we need to have conversations. We need to have community level conversations with our minority health partners, as well as our community partners abroad, because we can see and anticipate that as Mr. O'Donnell said, maybe 2-3 years from now, it may have an impact on our healthcare system, and it may not be COVID-related cases, but the stress and strain on responding to ongoing health care. And we want them, and we definitely don't want those long COVID cases to manifest itself into more chronic illnesses and more underlying health conditions, which causes an even more burden on the healthcare system and stresses. So we're looking at that. We haven't gotten there. We start responding, and then we try to move to recovery, and then we start responding again. So we just need to be able to sit down and have those conversations and look at the clinical aspects of COVID outside of just contracting the virus.
I also think that I mentioned we've just created a treatment page. I think that would be a great location to link resources for people who are experiencing long COVID. And again, currently within the public health realm, it could be covering a number of different syndromes that have to be teased apart. But there is currently information about guidance on what to do if you have it, or if you're a caregiver for someone who has it, because it can be very debilitating.
And Councilmember Rice, just to add to that, Sean, Mr. O'Donnell jogged my memory on something, the display where we had the antiviral treatment and locations. What we've learned throughout these past 26 months is communication is the key. And so we want to make our website more robust. We want to make sure it's easily accessible. So along to having those treatment modalities, we have our community level transmission on there as well. So you will see medium. That's an indication. We don't have mask mandates, but it's an indicator to the public. Hey, if you're traveling, even if you're traveling to the Northeast Corridor, you may want to consider strongly wearing a mask in indoor settings. And so we're starting to do more of that now as we look at the new or next normal, because these things will impact where we go from here. We have to go through the summer, and then we have the fall. And part of that wastewater surveillance early detection, we anticipate that we're able to forecast and anticipate any surges or any needs to increase or have a heightened public health awareness. And so those are the steps that we're making now in anticipation of any fall needs.
Thank you both. Just, I guess the headline here is it's back, but it never really left. So, the things are confusing. But as they have been since the beginning, but what is clear is if you are eligible and have not gotten a booster in the last 6 months, you need to do so. And parents with children between the ages of 5 and 11 are strongly encouraged, once that becomes available, to do so as well. And we are going to have to continue to take precautions with regards to masks, but there are no plans currently to mandate. Right now, these are just strongly encouraged. And I see some of my colleagues, I was wearing a mask earlier today. We are obviously having to be continuing to be cautious. So thank you both very much for joining us. We will schedule these as necessary moving forward, depending on how things go, but we continue to appreciate your leadership.
Thank you, Council President Albernos and the entire council. Good afternoon.
Great. Colleagues, we'll move on to the last item on today's agenda. which shouldn't take long. It's a district council session, item number 22. This is a little bit more of a formality. It's a resolution to extend the time for the council action on Thrive Montgomery 2050 plan from May 19 to July 18. Just for the public's awareness, there is a obligation that this has to be renewed every 60 days. And as we noted, we are in the midst of conducting further analysis and community engagement, particularly from those communities who understandably did not feel engaged in this process and would be disproportionately impacted by Thrive. This in no way demonstrates our lack of commitment to ensuring this important document move forward. It just acknowledges the practical logistical reality that we are not going to complete this by the end of this month. So we will be getting a more formal briefing on this at a later date, but just wanted to provide that as context. So can I get a motion to accept the resolution to extend the time for council action on Thrive from May 19 to July 18th?
So moved.
Moved by Councilmember Katz, seconded by Councilmember Navarro. Any discussion? No discussion. All those in favor, please raise your hands. And that is unanimous among all those present in virtual. Great, colleagues, thank you all very much. With that, we are adjourned.